Okay, let's get started. So you can all see my screen okay? Yeah, fantastic. So before I begin, I will introduce myself. My name is Poana and I am the clinical director. I'm a senior clinical director at Clarity Healthcare. I'm a senior psychologist and a family therapist. My experience is predominantly working with families and families and individuals across the lifespan with a specific interest in adverse childhood experiences, PTSD and complex PTSD. My co-facilitator today is Dr. Matthew Warden, who is the Chief Medical Officer at Clarity Healthcare. He's a consultant psychiatrist. So Dr. Warden brings significant experience across public and private mental health services in Australia and the UK. His previous roles include Director of Acute Inpatient Services, ECT and MHA Governance at St Vincent's Hospital, Consultant Psychiatrist in the Hobart and Southern Districts Community Mental Health Teams, and he's also a member of the Mental Health Act Tribunal in Tasmania. Dr. Warden has also held academic roles with the University of Melbourne. So before we begin, an acknowledgement of country. The Northwestern Melbourne Primary Health Network and Clarity Healthcare would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boonwurrung people, and the Wathaurong people. We pay our respects to elders past, present and emerging, as well as pay our respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just a little bit of housekeeping for everybody. Please ensure that your microphones are muted. We want to avoid as much background noise as we can. Ask any questions you like through the chat box. Please be mindful that this session is also being recorded. And also ensure that you've joined the session using the name you registered with, so we can mark your attendance. Certificates and CPD will not be issued if we can't confirm your attendance. So how to change your name on Zoom. Instructions on the screen, just click on participants. If you're using the app, click on your name. If you're using a desktop, hover over your name and click the 3 dots. If you're using a Mac, hover over your name and click more. Just need to click rename and then remember to enter the name that you have registered with and click done. I'm going to give everybody about 30 seconds to do that, and then I'll move on. Alrighty. Thanks for that, everybody. Agenda for tonight's session, the 5 minutes of intros and housekeeping. Following this, we'll have the education component of identifying and treating depression in general practice presented by Dr. Warden. Following that, there'll be 2 case studies, one that Dr. Warden will present and one that I'll present. That'll go for about 30 minutes. Then reflection on complex cases of depression, a question and answer session. We'll then have 5 minutes of one of the team from the referral and access team talking about head to health and care in mind and referral pathways, and then we'll finish. Okay, I'll hand it over. You go, Matthew.
Thanks very much. Good evening, everybody. Thanks very much for coming, and thanks to the PHN for organising this and asking us to be here. I'm going to really present to you the relevant part of my college's guidelines, which were published 2 or 3 years ago. The main author is Jin Marley, who's up at the University of Sydney. The reason I'm going to present them is, firstly, I think adherence to guidelines and protocols is really important in medicine, particularly important in psychiatry, and we're very bad at dealing with things in a algorithm type way. So this is a way of dealing with depression we should all be following. The second is that they are quite a significant departure from previous practice, and I suspect that there will be parts of them that are new to you in terms of the recommended way we treat depression. So hopefully that's useful for you. If you're interested, if you just type in RANZCP mood guidelines into Google, you can download it and see the whole article and so on. So that is available for you. So the first interesting thing they've done is to divide the symptoms of mood disorders into 3 groups, which are activity, cognition, and emotion. And on this particular diagram, those are given red, green, and blue colors. The ones going down from the midline are the ones with depression, and we're only focusing on depression tonight, so ignore the ones above the line, which are symptoms of mania. And the important thing is that you can have depression with only green and blue symptoms. So the mood part is not essential, and it is an overall picture of these symptoms that we're trying to build up when we're trying to decide whether somebody has depression or not. The other really important part of it is to remember that depression is not just a disease of the brain, it's a disease of the entire body. And so just the psychological part of feeling depressed is only a small part of it. And changes to our cognitive ability, our physical ability, and our biological symptoms are also a really important part of depression. And we shouldn't forget how important they are, both in terms of functional loss, but also in terms of recovery as well. The other thing to remember is that we are only talking about major depression, depressive illness today. When you see someone with depression, do not forget that depression is also part of bipolar disorder, and that is often missed. And the reason why that's missed is that people with bipolar disorder, firstly, at the beginning of their illness, will present with episodes of depression without mania for often a few years. That depression is likely to be atypical and poorly respond to treatment, but the development of elevated symptoms may be delayed for some time. So if you have somebody who is in their early 20s, who has repeated episodes of depression, which don't seem to respond to the treatment you're giving, worth remembering to ask whether in between you're seeing them, whether there are periods of different behavior. And if in between they or their family are telling you that they're quite different and they're full of energy and buying super yachts or whatever, then it's important not to miss bipolar disorder. People tend to only present to their practitioners when they're depressed. People don't present with mania because they're having a great time. So that's an important part. But we'll spend today thinking about depression and about how we diagnose depression and how we might try and treat that. Just to press the those symptom groups further, in our thinking about depression, we will be thinking of somebody who has symptoms which are typical and symptoms which are in sync. There are many cases where people have a thing called a mixed affective state, again, more common in bipolar disorder, but certainly is common in depression. And that is really best described by people whose symptom groups are out of sync. So they might have, for example, lots of the emotional symptoms of depression, but not have any of the more physical symptoms of depression. And they may have increased energy or increased appetite, even though they're depressed. So those things can be out of sync. slightly less common in depression. And if you do see those things in depression, you may be wise to really consider whether that person is actually having a bipolar disorder rather than a pure major depressive disorder. But that can be a real confusion if people have an out of sync symptom profile. This slide is again to remind us about the fact that depression is a whole body illness. And this hopes to begin to get us to understand a little bit about how that happens. Firstly, through the hypothalamus and affecting the autonomic system with increased dysfunction of the autonomic system, and particularly around cortisol and the adrenal gland. And we know now that chronic depression and chronic dysfunction of those systems actually significantly increases cardiovascular and metabolic disease risk. So people with depression actually are at higher risk of cardiovascular and metabolic disease because of their depression, not because of their treatment, but because of their depression. The other thing to remember is through the vagus nerve, our heart is connected to our brain, and the heart and that nervous pathway can actually control our mood quite significantly. People with depression will often have a bradycardia, and people can treat their depression with physical activity, which we'll talk a little bit about later on. And increasing your heart rate actually can improve your mood, again, by that neural pathway. So there are other organs external to the brain which can directly affect our depression. And perhaps most importantly, the hippocampus, which is affected by depression. And it is affected by depression because depression is a neuroinflammatory process. Most of our serious mental illnesses, we believe, are neuroinflammatory processes. And as part of that chronic inflammation process, we see decreased neurogenesis, decreased neural integrity, and decreased dendritic sprouting. So actually, we're beginning to see brain damage because of depression. And that is a relatively new finding. When I trained in London in the last millennium, we knew that schizophrenia was bad for your brain. We didn't think depression was. And now we know that chronic depression, untreated depression, actually causes neuronal death, not quite as severely as schizophrenia does, but significantly. So there is an urgency and a need to treat this as well. So just to remember, depression is an all-of-body illness, and it affects not only the brain and not only the emotions, but also the whole of the functioning of the body. The other thing that's really important in depression is sleep. We've known this for a long time. Before we had antidepressants, a treatment for depression was keeping people awake, and people would be kept awake for about 36 hours, and there would be an increase in their mood. And we still know that now, if people don't sleep, actually their mood goes up and they tend to become a bit irritable. And that is a really significant way of very temporarily improving people's mood. And we know now increasingly that external factors, particularly sunlight, and people's ability to maintain their circadian rhythm is a really important part of depression. And there is certainly a lot of research, mainly by Ian Hickey up in Sydney, around sleep and depression, and particular subtypes of depression that may be linked directly to disorders of circadian rhythm. So the way the system is supposed to work is that the sun hits our eyes hit our hypothalamic nuclei, and then those go through different pathways which adapt to the sun, and that adjusts our 24-hour rhythms. And through our 24-hour circadian rhythms, that affects gene expression, neurocognition, affect, and behavior. So that has a direct effect on our mood. And that is supposed to shift along with the seasons, as it were, as the daylight gets longer and shorter. There are lots and lots of people who don't adjust properly to circadian signals, and those people would appear to be at risk of depression. And that depression is treated significantly by improving their sleep. So it's a small group of people, but those people need to have their sleep improved, and that is the cure for their depression, more than the need to change the cognitive processes in their brain. So sleep is really important. It's really important in most mental illnesses, but being aware of sleep, trying to get a decent sleep history, initial insomnia is a huge problem with most people. Restless sleep, waking frequently, and also early morning waking. And trying to correct those is relatively straightforward to do, and can make a massive difference in people's mental state, and very quickly as well. So always worth thinking about that. I would suggest that we underuse the Z drugs. Certainly there's a lot of concern about Z drugs. If you look at the data around them, there's an awful lot of case reports of people reporting all sorts of horrific things with Z drugs. But if you look at actually the randomized controlled studies, problems with zopiclone and zolpidem are very rare, and I use them an awful lot, and I don't see any great problems with them. And I think actually we are doing our patients a huge disservice if we don't address their sleep problems effectively. And I think pure drugs like sleeping pills are much better to use than things like quetiapine, which even at low dose causes quite significant metabolic problems. So certainly don't forget about sleep. But apart from sleep, why do people get depressed? Well, it's very complicated. There is a genetic element. We do inherit a predisposition for depression from our parents, but in a very complicated way. There are probably between 60 and 100 genes involved in depression. They are mixed up as well with the genes for schizophrenia and autism and bipolar disorder. So it is not easy to say that because one of your parents has depression, you're particularly likely to have depression, you're particularly likely to have a mental illness, but it may not be depression. There is a huge variation in that, but certainly mental illnesses in general run in families, but they don't tend to run terribly pure. Of more importance than that is environmental factors, and particularly environmental factors in childhood. Certainly the biggest cause of disability in mental health and of almost all of our mental illnesses, but including very specifically depression, is childhood trauma. Abuse we know about, and we might be aware of that, but even subtle things like invalidating parents, where it may not seem like a hugely traumatic thing, but these things do affect children. They do carry those into adulthood, and they are often expressed as quite significant depression. Do not forget also the old-fashioned thinking that episodes of depression are linked to adverse life events. This is a stress vulnerability model, and in adults, in people who have chronically high stress, they are particularly prone to depression. And if they have a genetic vulnerability as well, they're even more prone. So if people have lives that are stressful or childhood trauma, they are at high risk of depression, and understanding the connection between those is really important in being clear about what might be going on for them. So we try and pull things together, and we're trying to make a formulation about what's going on for people. We think about age. Depression can happen at any age. However, you are much more likely to see somebody who begins to have depression early in life, and they may have recurrent episodes of it, but certainly it can happen at any age. Women tend to present more with depression than men. I think that's a bit historical, and I think that is evening up now, and men are presenting with depression more and more, and probably there isn't a genetic difference. It's been a presentation difference. Family history is important, both in terms of genetics, but also in terms of the effect of growing up with a parent who's depressed, and that is a trauma. That's not a genetic thing, that's a trauma, but also attachment issues and losses and neglect. Developmental history as well. School can be very good for children, can be very difficult for children, relationships, all those sorts of things. These are all predisposing people towards this. We then think about the patient specifically, We think about their diagnosis. Is it depression? Is there a subtype of depression? What sort of symptoms do they have? Do they have anxiety? Is substance misuse involved? There are huge problems with substance misuse. We used to think about alcohol. We now think more and more about other drugs, cannabis particularly, methamphetamine, stimulants. All of these things may be predisposing people to depression, but people may also increasingly be using to treat their depression, and we see that an awful lot. And then we have the really sticky one of personality factors. And I'm not going to talk too much about personality disorders today. Personality disorders and depression is very complicated. Things like chronic feelings of emptiness, chronic suicidality, emotional instability, problems with peer relationships, which are core symptoms of emotionally unstable personality disorder, are often mistaken for depression. And in those cases, those patients will not respond to antidepressants in a particularly meaningful way. However, because those people have chronic stress in their lives, they are also prone to a separate parallel depressive illness, and that will ameliorate with treatment. So, and that's sometimes a really difficult decision to make. But just because someone's got a personality disorder doesn't mean they're not depressed. It also doesn't mean they are depressed. And trying to tease that out is a really important part of planning treatment for that person. People with depression have lots of comorbidities. Diabetes is endemic in our society almost. People with depression have diabetes as well. Diabetes, any chronic illness, will dramatically increase the rates of depression in people. And then we need to think about what treatments we're going to use, and we're going to talk about that in a minute. But we fundamentally have psychological treatments, physical treatments, and medications, and we'll talk about those. The last thing to remember in terms of our formulation is the pattern of illness. Most people who have depression will have episodic depression. They will have a period of depression that either self-resolves or is resolved by treatment, or is resolved by a decrease in whatever the stress is in their life. Most people will have precipitants to their depression and will be able to work out why they're depressed. And it's also really important to think about what treatments they've had before, if any, and use that to try and work out what treatment might be best for them. There's a couple of things probably to be careful about there. I have seen, and I think it might be waning a bit now, a lot of people who have the view that if you have depression, if your mum had depression and your mum took drug X, then you should take drug X because there's a genetic component to it. I'm not sure there's a great deal of evidence for that. And I don't think that should be particularly how we make our choices about medication. The other thing is to be very careful about the sort of simple algorithm that you should take whatever medication you took last time you were ill again. That might be a really good thing to do if they made a really good recovery. But if they're back in front of you with a relapse of their illness, it may well be that actually wasn't a brilliant treatment for them. And so that their response to that treatment needs to be quite carefully thought about. I think a lot of revolving door type patients end up being so because the medication they're on is okay, but it's not good enough to actually get them into full remission. So whilst that's important, you need to make sure that whatever treatment they've had before, has that actually led to full resolution of their symptoms and full remission, or has it just partially treated them and they've had problems with it? So this is the guidelines divide level of care into 5 levels, and we're going to think about the first 3. 4 and 5 are for people going into hospital, so we don't need to think about that. Level 1 is very much in general practice. It's people with mild depression who may border on not having depression, chronic stress disorders, that sort of thing. These people are ideal for some of the things we're going to talk to you about, some of the self-help groups, some online sort of resources, probably lifestyle changes is the main thing for them. Self-help they probably don't occupy a huge amount of our time. Level 2, GPs, community service. This is where yourselves and ourselves are seeing a lot of patients. These are mild to moderate depressed people. And these people go into our stepped care model, which we'll show in a second. And then the next stage up is for people with more severe depression. And for that sort of thing, we're talking about people who failed treatment. So we've had a go at treating them. The standard treatments that we haven't worked, whether they've got other things like psychosis going on, whether they've got melancholia, which used to be called, or it's called in ICD, it's called biological depression. And these are people with very significant physical symptoms, or whether there's a very significant impairment, so they're unable to care for themselves. And these are people who need more specialist care, and they should be moving into psychiatry and psychology care. And we have them covered in the step care model as well. So that's how the guidelines view the different severities of depression. And this is our step care model, and it's pretty straightforward. We start off with lifestyle changes, and this applies to everybody. They are really, really important, and they do make a big difference. And that includes getting them to sleep, getting them to exercise, looking at their diet, huge amount of work into diet around ultra-processed food and avoiding that, but also things like Mediterranean diet. A lot of research from Melbourne around the Mediterranean diet show that it has a huge effect in improving depression and depressive symptoms. Looking at stress in their lives, avoiding shift work if they can, all of those sorts of things are really important. They are relatively straightforward to do, and they do make a really big difference. And all of these people at this level should be offered psychological interventions. And because Pawan is talking about those, I'm not going to talk a huge amount about those. But that is the first step for everybody. So psychology and lifestyle first for mild to moderate depression. If then they don't get better, if they get better and their symptoms improve, that's the end of their treatment protocol. If they don't get better, then we look at starting medication, and that might be a single medication or it might be multiple medications. And if that then fails and they don't get better, that's when we're looking at inpatient care at ECT, TMS, all that sort of thing. And we're not going to cover very much about that. So that's our step care model. And we are interested in actions and choices on that graph. Those are the bits that we're thinking about in our group of people with depression. This is the only thing I'm going to say about psychological treatment. It needs to be done by people who are both qualified and skilled and practice it all the time. The evidence base for psychological treatment is good. We know that it works, but all of that evidence is seen in people who are doing, who are professionals, who are trained doing therapies in a very pure way, and not doing, which I think is increasingly common, a bit of this and a bit of that, and their own made-up psychology. That we don't have any evidence for that. And if we're trying to do evidence-based treatment, we need to try and stick to those things. So if you're not, and I'm not well, I have done training in CBT, but it was a very long time ago. If you're not confident in doing it, and if you don't do it routinely, it is unlikely to be helpful. And you need to send somebody to your patients to see somebody who does this all the time. And that's really, really important to do that. So getting people in front of trained psychologists, mental health social workers, occupational therapists who are qualified in giving the therapy that you want is really important. And giving them the therapy that's evidence-based for what's wrong with them is really important as well. So for depression, we are looking at things like CBT, and that's really important. Mindfulness does not have an evidence base in depression. It may be helpful to some extent, but it is not one of the evidence-based treatments. So we need to make sure that in the same way that we prescribe the correct drugs for people, we prescribe the correct psychology for people. These are the options that we've got. Head to Health. Head to Health is a federal scheme. We are one of the head to health providers in Melbourne. And that's a way of people getting psychology and psychiatry appointments with no gap. limited number of sessions, unfortunately, but that's certainly a very useful thing. And then there are a number of other online things. This Way Up we use a lot, and that would be available for GPs as well. And that's a really good evidence-based, fundamentally CBT program that can really help people do things as well. So these things are available, and this is what we should be offering people at the mild to moderate stage early on, to say there are things available for you and we can get on and start those things straight away. In terms of medication, this is a list, a confusing list of all the different classes of antidepressants that we've got. Not all of these are available in Australia. Many of them are. It is not something that you need to have memorized or anything like that, but just to note there are an awful lot, and they are all slightly different. The question is, how important is that difference? And this is a breakdown of the differences they have. You will see that even though they're in different classes, in terms of what they do, most of them are postsynaptic, and they act at the 5-HT2 and alpha and histaminic receptors. And that is fairly common across most of our antidepressants. So although they're in different classes, and although we are told they do different things, most of them actually do exactly the same thing at a cellular level. There are some different ones. Agomelatine is different. It is a melatonergic antidepressant, and it is different in its action. The monoamine oxidase inhibitors are different in their action. And at the bottom there, if you can see that, vortioxetine is a presynaptic agent, and that's different. But fundamentally, most of the antidepressants are doing largely the same thing in terms of their positive action in the brain, in terms of the way that they treat depression. Where they're not the same is in terms of side effects. And actually, when we're choosing antidepressants, the side effect profile is really important, and to match that side effect profile against the patient in front of you. And I think this is a really useful diagram in terms of trying to separate those out. So that would seem to be an important thing when we're choosing antidepressants. What are the side effects that are going to be a problem for our patient? And we can try and predict which side effects they're likely or less likely to get with the different medications that we've got. So that might be a more useful grouping than actually mode of action. In terms of simple supplements, the top one is a little bit esoteric. There are some people with a genetic polymorphism. Don't worry about that. It's very rare. It won't involve you. Omega-3 fatty acids, I appreciate that they are mentioned in health and in mental health all the time, and they are always going to cure the world, and they never do. But there is actually quite a lot of evidence that very high dose, good quality omega-3 acids are actually helpful in depression. They're very simple to take. They're certainly not bad for people. And it wouldn't be a bad idea to encourage people to take that, but it is high dose that they need. I think it's something like 300 milligrams a day. So it's the very concentrated ones that you need. A note about St. John's wort. I haven't had a question about St. John's wort for a long time. I think it has dropped out of fashion to some extent. It does have an evidence base. It does treat depression. However, it is really quite good at precipitating mania, even in patients without bipolar disorder. So it is best avoided. And it is not actually as good as it is. It has more side effects and is not as good as SSRIs. So it's best avoided. The other one at the bottom, CBD, no evidence that we have for that in mood disorders. It is, as you know, being used more and more in a whole range of things. But in depression specifically, there seems to be, or there is no evidence at the moment that it's helpful in depression. And so this is the graph of this part of the talk. This is the bit that we need to remember, and this is the one that maybe you pin on the wall of your surgery to remind you. We start at the top. We see someone with depression. We look at their sleep. We get their sleep organized. We get them to exercise. We look at their diet. We get them off alcohol against other drugs that are either making them depressed or treating their depression. we stop them smoking, and stopping these people smoking is a really important thing to do. Education, it's important. There's a lot of online groups and education they can do. Psychological intervention, CBT, interpersonal therapy, all those sorts of things, which you'll hear about shortly. Social support. A lot of people's depression is caused by external factors. A lot of that is money, is their family, is not having a job, is not having a house. All of those sorts of things are important if we can do that. And then we look at medication, which is our next choice, and we try and pick the medication to fit the patient if we can, patient's symptoms if we can. So side effects is one, and this looks at side effects, and more tolerable agents are better than less tolerable ones, but also to think about the different receptor profiles that they have. So if the person isn't sleeping, perhaps mirtazapine is a good choice for them. Perhaps agomelatine is a good choice for them, because those are things that induce sleep. If the patient is very anxious, highly serotonergic drugs like SSRIs and SNRIs are likely to be helpful because they are better at treating anxiety. If the patient has cognitive problems, then a drug like vortioxetine, which has a very pro-cognitive drug, will be a good choice. If the patient is lethargic, bupropion, which is a dopaminergic drug, is a good choice. So that's a better way to choose antidepressants if we can. And all of that is explained within the guidelines if we're interested in reading it. But it's beginning, hopefully, to make us think about the choice of antidepressants in a very different way. And how we use those antidepressants is a bit that's really different. The very clear suggestion from the paper is that the way that we treat someone with antidepressants is that we choose the antidepressant, we give it to the patient. If the patient doesn't respond, we increase the dose. And after we've increased the dose, we augment. So we don't change antidepressants anymore from one to another due to poor or lack of response. We augment. And what we augment with is likely to be antipsychotics, particularly partial agonists. Augmentation with antipsychotics we've been doing for a long time. And partial agonists, which is cariprazine, aripiprazole, and brexpiprazole, are extremly good augmentation agents. Lorazepam is good as well, ziprasidone, there's a whole number of them. Low dose, low side effect antipsychotics as an augmentation agent is very good. Lithium is an augmentation agent we can use. It's a bit more complicated to use. It's a bit slower, but certainly a big evidence base for that. Thyroxine, which we used to use, very little evidence for that now, and that's best avoided. Lamotrigine, sometimes people use. The evidence base is not as good, but it certainly needs to be low dose lamotrigine if you're going to use that. Sodium valproate is not a drug to augment with. Sodium valproate is only an anti-manic drug and has no role in the treatment of depression. So those are the sorts of things we augment with. If augmentation fails, that's when we change to a different antidepressant, and we need to change to an antidepressant that is significantly different from the last one we chose. So if we had them on an SSRI, when we change, we would not change to another SSRI. There is no point to doing that. We need to find a different drug, and probably the more different you can make it, the better. So if you went from an SSRI to bupropion, that would be a good choice because you're doing something that's really quite different. But even changing to an SNRI would be a useful thing to do. When we're choosing our antidepressants, we now have to think about how we get people off them, because discontinuation syndrome is with us now. It is a very real thing. Can be an extremely unpleasant thing. This is the information that you need about discontinuation syndrome. The only important thing I'm going to say about this is that you need to tell patients when you're choosing an antidepressant for them that they may get discontinuation syndrome. And the drugs that are most likely to cause that are venlafaxine, desvenlafaxine, and paroxetine. And I would suggest that we need to be very careful before we give people those drugs, because it can be an extremely unpleasant experience coming off that. So that's an important part of our choice. It's an important part of our shared care protocol with patients. If they're on that drug and they've got they've either had some symptoms, they've missed a dose, and they've had some of the symptoms of discontinuation syndrome. What we have to do is to titrate down slowly. That's the only way to do it. It is possible to switch them over to a longer acting antidepressant. Discontinuation syndrome is associated with short half-lives. It is possible to swap them to fluoxetine, particularly, which is a very long half-life, but really slow drops with the smallest possible decrease each time is the way forwards. All of that information in the guidelines if you want to read it, but really important to consider that when you're choosing an antidepressant. And I will just whiz on quickly to my case study. My case study is a amalgamation of lots of patients that I see that are similar. I have specifically simplified it to make a point. The point I'm trying to make. So this is what I spend a large amount of my time seeing. These are people who are referred from either from Head to Health or from GPs. People with long-standing depression, often over many years. Nothing in trauma. We see lots and lots of patients with trauma, but for these sorts of patients, they don't have any significant trauma. They just have stress and they have long-standing depression, and they always have some degree of anxiety. Generally not too bad and not the most disabling thing that they've got, but quite significant anxiety, and specifically anxiety that is secondary to their depression. So their depression started first and their anxiety became an issue for them later on. The key thing they have, and the most important symptom on that funny chart that we saw right at the beginning, is anhedonia. If you're going to ask one question to diagnose depression, it is the presence of anhedonia. Are there things that you used to enjoy that you don't enjoy anymore? Is there anything in your life that brings you joy? And if they say no, they've almost certainly got depression. So significant anhedonia, really important symptom of depression, and can be separate from a low mood. But in most people, they have a persistent low mood as well. And in most people, they will have biological symptoms. So they will have sleep disturbance, they will have appetite disturbance, they will have sexual disturbance. And the presence of those three symptoms or groups of symptoms is really diagnostic of depression. So it's really important that we're clear about that. And in our classic patient, we're going to see all of those things being present. Past treatment. And this is pretty significant. This is pretty common. Many people will have tried a number of SSRIs, normally about 4 SSRIs. And most people would have tried an SNRI as well, or 2. So pretty typical, we've tried those. The important thing about that is that we really haven't tried a range of antidepressants. They've tried things that are pretty much the same, and we've forgotten about all those other antidepressants. So bupropion, MAOIs, agomelatine, vortioxetine, all these other drugs which may be effective, but we've just really repeated giving them pretty much the same drug every time, and they haven't responded. Most patients would have taken benzodiazepines as well. I think these are a really important part of treatment. They do provide immediate relief from anxiety and distress, and it's important that we use them sensibly, but we don't withhold them from patients because actually they almost certainly decrease patients' distress and improve their lives pretty quickly, and that's a really important part of that. So what would we do? So when I see these patients, I don't change their antidepressant. I say just keep taking whatever you're on at the moment. In this case, it's escitalopram. That's very widely used. I think it's a perfectly good SSRI. If we can increase the dose, we will. And, you know, I'm quite happy to go up to 30 or 40 milligrams of escitalopram if the patient can tolerate it. They often can't. So we get the dose as high as we can with patients having tolerable side effects. And then the next step is to augment. And the drug that I use almost exclusively is brexpiprazole. Brexpiprazole is a partial agonist at the D2 receptor, and I use 0.5 milligram. And that's such a small dose that you actually have to cut the smallest tablet in half. And they take that at night. It's possibly very mildly sedative. We add that in, and we see the patient after 3 weeks. And the norm is for that patient to say their mood is significantly improved. They will normally notice within a day or two of starting brexpiprazole, and that is absolutely evidence-based. That's how quickly these augmentation drugs can work. However, just because they feel better, that's not good enough. And when we treat depression, we need to treat to the point of resolution of all symptoms. So we need to keep asking them, have you got any symptoms of depression left? If you have, we need to keep treating those, whether it's psychological or pharmacological treatment. Once we've resolved all of their symptoms, we've got the patient in remission. And then the job is to keep them in remission to 6 to 12 months. If you do that, if the patient remains symptom-free over that length of time, there are options to cease the medication. And the evidence suggests that 75% of patients who've been in remission for long enough will never have another episode of depression. And the remaining 25% will have a very variable course. Some people will become depressed almost immediately, and those are people who need long-term treatment. And some people will have another episode in a few years' time. But if you get them to remission, most people can stop their medication, or at least have the option to do that. And that is my last slide, and I will hand you over to Kawana.
Hi, everybody. Thank you, Matthew. That was great. So today, really brief case study on treating depression using psychotherapy. What I've got on the screen is the diagnostic criteria from the DSM for a major depressive disorder. So always kind of keeping that in the back of my mind when I receive a referral for a client. Today, I'll be talking about a de-identified client named Sarah, who experienced significant impairment in her daily functioning due to her depressive symptoms. This study is going to briefly outline background, presenting problems, a bit of the treatment process that I used, interventions, and the outcomes I achieved using interpersonal psychotherapy. So Sarah, so interpersonal psychotherapy is the gold standard evidence-based treatment for mood disorders. So Sarah is a 32-year-old woman, employed full-time, presented with a history of recurrent depressive episodes, with a current episode lasting for about 6 months. She reported experiencing low mood, fatigue, sleep disturbances, difficulty with onset and maintenance, and decreased motivation. She described feeling disconnected from her friends and family, which further exacerbated her feelings of loneliness and worthlessness. So Sarah's depressive symptoms significantly impacted her work performance as well, leading to frequent absences and decreased productivity. She struggled with maintaining relationships and often avoided social interactions and isolated herself often from others. She expressed feelings of guilt, self-blame, and believing that she was a burden to her loved ones. Despite previous attempts at therapy and medication, Sarah also reported to me that she was over-relying on her GP for support with her depressive symptoms. So when I'm beginning the treatment process, I'm always thinking about a biopsychosocial assessment and using scales and questionnaires that might work with my hypothesis. So in this case, I started with the Beck Depression Inventory. So the Beck Depression Inventory, it's a free diagnostic tool and anybody can use it online. It specifically evaluates key symptoms of depression. So Sarah scored between 31 to 40. If you can see on the screen, I have the criteria on there. 31 to 40 indicates severe depression. So I thought I'm going to administer another screen just to ensure validity and cross-reference. The next screen that I chose to use was the PHQ-9. So this is an instrument for the identification of mild, moderately severe, and severe depression, with questions asked for a reference period of the last 2 weeks. And again, this is a free screener that's used that you can find online. I always use 2 screeners again to consider a differential diagnosis, and both of these screeners were administered at monthly intervals to monitor the client's outcomes. So with the PHQ-9, Sarah scored between 20 to 27, indicating severe depression. So following thorough assessment and formulation, I landed on the key areas that perpetuated her distress and in a way kept her stuck. So initially I talked about the recurrent depressive episodes that had happened through her adult life. Now, this is really brief, and I wish I had a lot more time to talk to you about this intervention through interpersonal psychotherapy. But what we landed on was a couple of different areas that perpetuated her distress. The first being grief. So Matthew talked a little bit about adverse childhood experiences and, the impact of stress in one's life on depression. For Sarah, she struggled with unresolved grief following the loss of her father several years ago. I facilitated discussions, specifically using emotion-focused therapy to help her process her feelings of loss and sadness. She was able to work through the unresolved grief. Next were role transitions in Sarah's life. So she recently experienced a significant role transition at work, which exacerbated her feelings of inadequacy and self-doubt. I supported her in adjusting to her new role and exploring coping strategies and building confidence in her abilities. Interpersonal disputes. So Sarah harbored unresolved conflicts with her mother, stemming from childhood resentment and unmet expectations. Similar to what Matthew was talking about, is that not everything is a big trauma in childhood, but punitive parenting, emotionally unavailable parents are all traumas that impact young people and then lead to severe depressive symptoms in adolescence and adulthood. So I use some strategies for assertiveness and healthy communication to process the unresolved feelings that kept her stuck. Last intervention, interpersonal deficits. Sarah struggled with assertiveness and expressing her needs in relationships. I utilised some role-playing exercises, communication skills training to enhance the effectiveness and assertiveness. Now please keep in mind, really brief overview of the intervention. So this case study really highlights the effectiveness of interpersonal psychotherapy in treating a major depressive disorder by addressing the interpersonal issues. Through targeted interventions, Sarah experienced significant symptom relief and improved interpersonal functioning. Interpersonal psychotherapy offers a structured and evidence-based approach to treating depression. It really emphasises interpersonal relationships and the role of community in mental health recovery. And to mention, it's a really time-limited intervention. It's manualised, it's structured. With Sarah, I utilised 15 sessions, and at the end of our treatment, I administered again the Beck Depression Inventory and the PHQ-9 once again, which indicated high levels of symptom relief. So interpersonal psychotherapy, what is it? So like I said, it's time limited and it focuses on the interpersonal issues, which are understood to be a factor in the genesis and maintenance of psychological distress. Interpersonal psychotherapy is a form of cognitive behaviour therapy. However, the model is more effective in treating a major depressive disorder as it takes steps from psychoanalytic theories to focus on the underlying issues of the problem and not just what the patient is presenting with at the time of assessment. So if I can highlight, Sarah presented to me and said, my issues are that I'm having frequent absences from work. And she thought that if she can get a hold of that she won't feel depressed anymore. But if you remember the interventions, they kind of borderline on thinking about her childhood dynamics and thinking about the interpersonal and social dynamics in her life. So the interpersonal triad. Interpersonal psychotherapy is explicitly based on the biopsychosocial, cultural and spiritual model. It works on the premise that the interpersonal distress is connected with psychological symptoms. So the key factor, the difference between CBT and interpersonal psychotherapy, even though they're quite similar, is the interpersonal triad, which you can see on the screen. So it suggests that depression, mood disorders, and other mental disorders usually begin after an acute crisis. The crisis may be somewhat relieved or it might be exacerbated depending on the client's attachment style, their biopsychosocial, cultural, spiritual strengths and weaknesses. So if a client has an inadequate social support system, the problem with major depressive disorder may be compounded further. The interpersonal triad, like you can see on the screen, is viewed as the combination of factors that may add up to the cause of a client's distress. So the triad includes what you can see here, the interpersonal crisis. It could be something like a problematic relationship. It could be grief. It could be trauma. It could be a difficult life transition. We consider the strengths and vulnerabilities of the client. And like I mentioned earlier, we really want to consider the client's attachment style, personality traits, and temperament. Additionally, cultural, spiritual strengths and deficits, really important. And then thinking about social support. Matthew mentioned this earlier, but social support and community is really, really important in mental health recovery. So brief overview there. So when treating a major depressive disorder, I'm going to always look at using CBT or interpersonal psychotherapy because they are the gold standard and evidence-based interventions. And like Matthew mentioned, best for them to be administered by an individual, a psychologist, a mental health social worker, somebody who does this often, does this daily, and does it, in a manualized and systematic way. So now I am going to move on to health pathways. I'm sure that you all know about health pathways and what it is, but I'll speak a little bit about it. So health pathways is a collaborative online resource developed by Eastern Melbourne and Northwestern Primary Health Network in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website access to a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. So this screenshot here highlights the location in the table of contents where you find the relevant pages relating to identifying and treating depression in general practice. So if you look at the screenshot on the screen, to the left of the page is where you might find some resources related to the discussion tonight, treating depression. So if you can see the yellow highlighted, you might log in, you might click on mental health, you might find some resources related to child and youth mental health, depression in children, depression in adults. You can scroll through all of these resources. There's also a tab at the top of the page, a little search bar, and you can also enter, depression or whatever it is in there, and it'll come up with different updates and kind of, most evidence-based treatments in there as well. So the process of developing content for health pathways is a collaborative effort between our local GPs, specialists, allied health providers, and other subject matter experts. Each pathway is evidence-informed, but also reflects local realities. Health Pathways aims to enhance clinical knowledge and promote best practice. It aims to reduce variation in care, and it improves the quality of pre-referral work up and to reduce delays with referrals. It also provides you with information on local services available to your patients. Some relevant and related pages and access for you in terms of what you might find on health pathways, depression in older adults, medication for depression in adults, medication for depression in older adults. So you can scroll through all of these resources and choose what's most relevant to you and your client. Again, more relevant pathways and pages that you might find on health pathways. Now, accessing health pathways, I'm sure many of you have access to health pathways, but for those of you who don't. So to access it, there is a website which you can see at the top of the screen. It is melbourne.healthpathways.org.au. Health Pathways is available to general practice teams and other clinicians in the Eastern and Northwestern Melbourne PHN catchment areas. So if you don't have access yet, you can click on, so if you have a look at the screen where my cursor is, register now, this red circle here. Once you click on that, it brings up an online form. We can also organise automatic login for you, so you can access Health Pathways without a username and password. If you'd like to do that, you can just email the team on info@healthpathwaysmelbourne.org.au, bottom right hand of the screen. That email address is there for you. Now, I was going to attempt to share my screen and go through the Health Pathways web page live for you, but I'm actually not going to do that. I think this will suffice. That's the end of the case studies and Health Pathways. Right now, we have some time for reflection on complex cases of depression in general practice. And what we can do in this space is really use it so that it's helpful for all the attendees. We can engage in a large group discussion regarding your experiences in identifying and treating depression, or you can ask Matthew and myself any questions that you have. So I might just open up the floor to anybody who has questions or some reflections. Okay. Elisa, are you able to check the chat box
Yeah, just
for me? Is any in there?
there's a 3 in there, so are you able to see them on your end?
Let's have a look. Okay.
Otherwise, I'll read them out to you.
Okay, the first question I'm assuming is for Matthew. Is transcranial magnetic stimulation useful in patients at level 2 or 3 of depression?
I think it's pretty clear that its effect is in the milder end of depression. It's probably most useful in people who have a lot of biological symptoms, a lot of physical symptoms, or people who've had problems with tolerance for antidepressants. It is not something that I would be suggesting somebody with very severe depression has. It's in my experience, in my opinion, it is not a hugely useful tool. But having said that, I have a handful of patients for whom it has been quite transformational. So yes, it can be helpful. It's hugely time consuming. It's 50 sessions over a number of weeks, often 3 or 4 times a week. And it takes a lot out of their time. It's difficult to fit that in with work or anything like that. It's very low side effect, which is helpful, but not for very severe depression in most cases.
Thank you. Stefan Wu asks, can you briefly explain the different evidence-based psychological therapies that are helpful for depression? It's really confusing when there are so many different terms and sometimes used loosely. Yeah, really good question, and I'll try and answer that for you. So the most evidence-based therapies are CBT and interpersonal psychotherapy. I would personally use interpersonal psychotherapy over CBT because it goes into the elements of childhood and the adverse childhood experiences, community, and relationships. So it kind of looks at the whole of the person, whereas CBT can sometimes be extremely manualized and we treat the individual in isolation. So both of them are evidence-based for treating major depressive disorder. And, I think it's more of a preference of who would use. Someone might use CBT and the other might use interpersonal psychotherapy. But personally, I would use the latter because of the in-depth intervention. You wouldn't use acceptance and commitment therapy. That's something that's really different, and I absolutely understand there would be so many different terms out there. Acceptance and commitment therapy might be for, you know, there's someone experiencing a life transition, grief, something like that, but you wouldn't use that with a major depressive disorder. Yeah, okay, so Stephen's asked another question around e-CBT and other online therapies. How do they differ apart from being online? You know what? We've moved into the online world now. Some of us psychologists are very old school. I prefer in-person sessions because of the relational element of the therapy and the transference between the client and I, so I can really understand what's happening. But the evidence base is there for online e-CBT and online modalities. It's really up to the client and what they prefer to engage in. I think we have to be really realistic that people work full time. Some people might not be able to leave the house. Some people after COVID only just really enjoy engaging online. So we have to be really flexible to get people engaged in treatment. The next question is from Victor. Victor asks, can we use quetiapine to augment treatment in depression?
We can do. Dose would be 100 to 200 milligrams. Quetiapine is a very effective mood molecule. The problem with it is it's a very high side effect molecule, and even at low doses, it does cause weight gain, it does cause increased appetite, it does cause lipid and glucose dysregulation. It also is very sedative, and it's sedative at lower doses. And the sedative effect will often, even if you give it at night, will often linger into the next day. So yes, it's very good, but it's not without side effect problems, even at low dose.
Thanks, Matthew. Wendy asks, will you share the recording of the webinar with those of us who have attended? Yes, absolutely. And that will be part of our closing slide. We'll share that and how to access this. Okay, no other questions? Thank you, everybody. Oh. Okay, I am going to hand over, sorry. Do I want to allow that? No. To Paulette Balcastro from the Northwest Melbourne PHN Referral and Access Team. Paulette, the floor is yours.
Thank you. Thanks, Paulana, and thank you everyone also for giving me this space and allowing me to highlight quite a unique team that this PHN has, and that is having a clinical team that sits within the PHN called the Referral and Access Team. And this is like a centralized intake team that manages referrals coming in for Head to Health and the Care in Mind services. The clinicians range, we're all very experienced clinicians with various backgrounds and disciplines. Some have worked in private practice, others have worked in mental health inpatient wards. So we have a really wonderful multidisciplinary team. The Head to Health and the Care in Mind suite of services offer a beautiful range from people who are experiencing mild suicidality, all the way through to people who are experiencing chronic and quite complex mental illness that can be managed in the community. It is worth noting, though, that we're not equipped or set up to be able to manage people in crisis in terms of suicidality. So if you have a patient presenting with acute suicide risk, then the triage is going to be able to assist you much more readily than we are. So the Head to Health and the Care in Mind services are set up for people who may not have easy access to psychological services, either because of they come from a vulnerable community or financial constraints. So the way to refer into this suite of services, the easiest way is just to use our referral form, which can be found on the PHN website. You can download it in Word, PDF, or any of the other formats that you might use within your practices. The referral form was designed in collaboration with our GP consultant. And so initially at the beginning of the referral form, it's looking at some of the eligibility criteria for these two specific services. And then it might go into sort of, it balloons out into demographics and presenting concerns. So really the more information we get at this point of the presentation really helps for the smooth and fast transition into care and services. We don't like to have waiting lists, but sometimes that processing time can hold up referrals. So information that's helpful is similar to what you've heard tonight. So looking at what their current presentation is, any changes in their mood, changes in their hygiene practices, level of enjoyment in activities, any history that they may provide with you. I know this sounds like a lot of work, but the referral form has also been designed so that you can claim the appointment as a mental health care plan preparation. So if you are speaking with someone who's not necessarily ready to engage or talk with anyone, they may be referred into some of those online services that Pawana talked about before, or you can also give them the Head to Health number, which is 1-800-595-212, and then they will be able to speak with one of our clinicians and do an intake assessment directly, and then we can navigate them into services that are going to meet their needs based on that intake assessment. So that's very brief, but thank you for the time. If you have any other questions or you would like to talk to us more, when you head to the website, particularly the Care in Mind website on the PHN, within the PHN larger website, there is a contact number that you as GPs can call and have a chat or a consultation with one of our clinicians as well. So that's very brief. But I will hand back to Pawana just to round things off. Thank you.
Thank you, Paulette. So that brings us to the end of our session. So we really value your feedback. So please let us know your thoughts. You can scan the QR code on the screen. You'll also receive a post-session email within a week, which will include all of these slides and resources discussed during this session. Your attendance certificates will be received within 4 to 6 weeks, and your CPD hours will be uploaded within 30 days. If you'd like to attend further education sessions, visit the link on your screen. And again, you'll have these notes and slides accessible to you in a week. This session was recorded, and you will be able to view the recording at the link below within a week. So Matthew and I from Clarity Healthcare would really like to thank you all for taking time out and being here and engaging in this session. The Northwest Melbourne PHN also would like to thank you all for being here, and please do have a lovely night. Thank you. Bye, everybody.